Hi, everybody. Welcome to the podcast Redesigning Normal. I'm your host, Andrew Southern, and today my guest is Sheila Davis, who's the Senior Executive Vice President of Operations for Always Best Care. Sheila, thank you for joining me.
Thank you for inviting me. It's a pleasure.
So, Sheila, could you tell us a little bit about Always Best Care and about your role there?
Yes. So Always Best Care was founded back in 1996. We offer private duty services and skilled services to people in their homes. And we also do assisted living placements. We have converted back in the early 2000s to a franchise system. So we are a franchise system now, and we have agencies in 32 states and Canada. We cover over 236 territories and have over 105 physical locations, and definitely growing, continuing to grow. We really go out into the homes and assist clients with activities of daily living, maybe meal preparation, errands, transportation, and then on the skilled side, of course, wound care, congestive heart failure, diabetic, and that sort. Myself, I have actually been in the industry for 33 years. I actually got a very young start. My mother was actually one of the very first home care administrators back when the program was designed in 1965. So literally grew up with the program, owned my agency for 18 years of that career. Once we sold our agency, then I got back into the corporate world. I really love the education and teaching aspect of it, and as well as the compliance aspect. And everybody thinks that's funny because who wants to sit down and read federal regulations?
Right.
But that kind of is my joy. I love diving into the regulatory side and really seeing what's going on and how maybe our organizations can advocate for our seniors and our disabled clients to ensure that they get better care going future. We service a great percentage of the population for veterans. So we're a very veteran heavy organization that services those veterans. And of course, as you already know, over the past couple of years, there has been a big advocacy to get all of those veterans off the waiting list and to get them care. That's what I do. I am over all of the operations. I'm basically second in command at Always Best Care. Over all the operations, I have a whole fleet of employees that work underneath me on the regional and national level to support our offices. Really, that's what we are there to do, is to provide the offices with the latest issues of compliance, regulatory aspects. And this past year, of course, was just helping and assisting them get through the pandemic, which was something I think that caught everybody in the healthcare industry off guard.
Wow. Okay. So that makes a lot of sense. In terms of Always Best Care, who's coming to the offices? Is it the patients themselves or the families of the patients that say, hey, we want to arrange for this care for our, let's say, our grandmother or something? Is that normally
Sure.
how it works? Okay.
No, we really don't have any office traffic. Most of our offices just house maybe the scheduler, the payroll clerk, the HR clerk, and whoever the owner is. Our services usually come either by word of mouth or directly from a physician's office or assisted living facility, or maybe just a family member that has been searching online for a care provider to provide for their family. Once they contact us, then we will actually set up a meeting to go to them. It can be in a family member's home, or it can actually be in the client's home and family members present. We actually go to their home to do the interview. So it's more of a relaxed setting for the client. We get a little bit of intake about what their surroundings are and what their conditions of living are. And then we sit down and we try and discuss what we feel might be the best road to care for them or what they need assistance with. And then we ask their input as well. And then we usually come to some sort of agreement on how often they want us to come, what time frame they want us to come, and then we go from there. All services really regarding the client and the patient are done in the home. We go to them.
Is it okay? And then do people pay for it directly, or can insurance pay for it in some cases?
So there is a whole plethora of platforms. Yes, they can pay privately on a cash basis or Visa card or debit card, but then it's also covered by long-term care insurance policies. The VA has a very successful what's called community care network that pays for services. And then, of course, now Medicare Advantage plans are also adding the ancillary private services into their plans. And of course, there's just some private insurance companies that do pay for it. And then in some states, there's some state programs like the PACE program, which is the program for the elderly, and of course then your Medicaid waiver programs also pay. So there's a whole variety of platforms that could pay for care, but there are some families that just choose to pay for it privately as well.
Got it. Okay. Let's back up to early 2020 when I think most people were hearing about COVID, and maybe your experience. Did you hear about it? When did you hear about it first? Do you remember?
Oh yes, very, very vaguely remember it. The CEO and I were actually in Cabo San Lucas, Mexico, with a group of our franchise owners. There was about 10 owners there. We were having a performance group meeting, which is a financial group meeting, and we were in Cabo. That was where they had chose to go for the meeting, and that was when we really first heard of it. We had been hearing of it overseas and what was going on, but
Sure.
not really anything coming to the United States. And during those 4 days that we were there, actually on the very last day, we didn't know if we were going to get to come home or if we were going to be stuck in Cabo for a few weeks. And of course, there was a few of us that didn't think that was a bad aspect of it, but now given hindsight of what it would have led to, that would have been a bad thing. So I was actually enjoying the beach when we first heard of it, and got back home, and immediately that's when everything really started to just blossom and bloom and blow up everywhere.
So I'm going to guess that your retreat was early March.
Yes.
Is that okay? Absolutely. All right. So then you get back from Cabo, and it becomes clear probably that this is now going to affect your business and your patients and your staff. So what did you do? You said earlier that you're interested in government regulations. So right off the bat, do you look to the government for some guidance on what to do with this new disease, or virus that's moving around?
Of course we did. Immediately we were in contact with the CDC because we knew that's where the guidance would come. I will tell you that the state regulatory bodies, as well as even some of the federal regulatory bodies, everyone was caught off guard. We are all mandated within our home care agencies to have what we call an emergency preparedness plan. And although we had those plans they were geared more to your natural disasters of hurricanes, floods, tornadoes, fires. We had added active shooter, and we had added spam and cyberware issues, but no one ever thought that we were going to be hit by a pandemic. None of us had an emergency plan that was actually geared towards that. And no one in the regulatory fields really knew how to enact anything at that point in time. So it really was really pure chaos those first 30 days, I will admit. Immediately within our industry, to be perfectly honest, as we discussed earlier, there is a significant portion of our clients that do pay for private pay. They were immediately fearful of people coming in and out of their homes. And so overall, I would say our organization was very highly concerned whether our business would even sustain through the pandemic, because you couldn't go into facilities. Many people didn't want you to come into their homes. Then the regulations started coming down. Infection control was immediately an aspect that we were proactive in implementing, but immediately there was infection control protocols that were put into place that really the non-medical private duty side had never dealt with anything infection control wise, except maybe, and that was our main PPE product. And we at the corporate office, of course, took on the initiative because PPE supplies were in such short demand, you couldn't find them anywhere in the United States. And if you did find it, it was just one or two. And of course, there was price gouging already. I actually took on the project on behalf of our FSO, and we collectively went out and found PPE that included masks, goggles, gowns, gloves, the whole plethora of PPE that was going to be needed to not only care for non-COVID clients, but COVID clients as well. And we were able to source in a great bulk and then distribute out to each one of our locations. So that was a good part that did happen to us. I do give kudos to Amazon. Amazon did set up an independent platform for medical providers only. You had to have certain credentials and regulatory clearance as a medical entity, and those entities could then access that COVID Amazon site. And there was a lot of PPE that was sourced through that, and they did a really good job of trying to keep in stock. And so that was one of our resources, as well as we went to many medical distribution centers of McKesson and Medline across the country to help us source those supplies. Along with that then came, of course, new policies and procedures that had to be put in place and new training. Caregivers weren't trained to don and doff PPE appropriately. There was a whole host of training that had to come into, and of course, with all that training and with implementing infection control and PPE, you had to cover yourself on the regulatory side. So there was a whole new policies and procedures that had to be incorporated as well for your caregivers and your staff to follow. It was really a very fast-paced month of April and May. I will tell you, we were just running around chasing our tails. And at that point in time is when we did see a slight decrease in our business go down. And it was probably the best thing that could have happened, because it did give us that little bit of opportunity to get everything in place and lined up. Then about June, we started seeing just the opposite effect take place. We saw a influx of clients actually wanting private duty services as the assisted living facilities and skilled nursing facilities became on lockdown. Many families didn't want to see their loved ones because we didn't know how long the lockdown would be enforced and take place. And so I would say there was probably about 30% of families that were capable of doing so. There's some people in skilled nursing facilities that don't have a lot of family, or only have maybe their elderly spouse or someone, and so they didn't have anyone that they could effectively go and stay with or live with. But for those that could, about 30% were removed from facilities of acute care type and were brought back home, and with such they needed that assistance of non-medical care to come in and help with assisted living.
Wow. Okay. So that
is where we really saw the influx.
Amazing. I want to go back for a second, because you are the Vice President of Operations. So when you guys were making changes in April and May and training and all these new things you had to follow, how do you get that information and that training out to people that are working, the staff, right? How do you get that out across all these different states? Did you pick Zoom and say, this is what we're going to be using from now on, and just start doing training like that? I'm just interested in how you got the message out to all the professionals that work for you.
Absolutely. First of all, we at the corporate office had to gather the data. So there was a lot of background work with the CDC, the Department of Health and Human Services on the federal level. I'm very blessed to serve on the boards at NAC and HCA. Our national organizations were able to provide information as well. There was also a committee formed within the HCAOA, which was a medical advisory committee. And I was actually asked to sit in on that committee as one of their co-chairmen. And so I did. And with a collective of other executives across the country, we facilitate that verbiage and that language that agencies needed to utilize. But going back to Always Best Care, it's exactly what you said. The virtual world became our world as we know it. And so we provided those trainings through, first of all, we would provide a digital training so that they would have it in writing and have it in front of them. And then basically it was a three-part step. First of all, we had to train the owners or the administrators of each given office on really what the regulatory side was and the CDC recommendations. There was another aspect of that most people don't realize is that there's the CDC recommendations that come out on a daily basis that is geared towards the general population, but then there's a whole different set of regulations from the CDC that is for healthcare entities and those people who are really in the healthcare field. And that was another issue of making sure that the caregivers and the staff understood the difference between what you're hearing on the streets from the CDC that pertain to the general population versus what pertains to you as a healthcare provider. So there was that education to the administrators first. Then the administrators provided education to whoever their supervisors are that oversee all of the staff members. And from there, really, it was a whole host of ideals. The supervisors either had to go out and meet the caregivers in the homes. They met in off-site locations. Of course, it was very few that could come at a time because we were at social distancing and full precautions at that time. And then they did a host of those trainings via Zoom. But the basic thing is a lot of those require a skills return demonstration. When you're teaching someone to don and doff PPE properly, You really can't do that over a
Right.
Zoom. You can, and you can watch to a certain extent, but it's really hard to see if somebody's doing it properly. Our supervisors were really in a scramble because especially if it's in a location that has a lot of 24/7 clients, you have 2 or 3 caregivers going into a particular home at different shifts. And so it's hard to gather all of the caregivers together at one point in time because everybody's doing different types of
Sure.
shift work. So there was a lot of ongoing trainings, just basically 24/7 around the
Amazing.
clock.
Amazing. Then as actually, there's so much here. So you're visiting people in their homes, and people are worried about people coming into their homes during COVID. And in this, to the same point, the folks, the staff that are going into people's homes may be worried about what's in that home. But they also have to render this care because this care is life supporting for folks. So whereas we might roll in the past and do our business and help our patients and then move out, now you've got a whole layer, literally a physical layer between you and the patient and all their. I'm interested to what happened over the summer. What was you mentioned there was a bounce in interest in home. Did you see?
Correct.
Was that a net? Did that make you more busy than you would normally be over a typical summer, or about the same? What did it do for the business?
It really took
Wow.
us into overdrive. We saw a influx of business across the nation. And I will tell you, it was really enlightening to see because we really, like you said, everyone and all of our franchise owners were just devastated in March, April, and May because many of them did not know whether they would get a PPP loan or not, but they still had to cover payroll and expenses. And there was a big devastation. I talked many people off the ledge because they just felt that their business was going under. And then, like I said, all of a sudden in June, it seemed like the month of June was the turning point. And from June until December 31st, we were probably the busiest that we have ever been in the history of our franchise system. We finished the year with, and I don't mean this to brag in any way, we finished the year with an all-time high revenue and an all-time high census, just because so many people had to turn to the private duty and non-medical side for that support in the home. And the other interesting factor is that Medicare in no form or fashion had ever fathomed that they might ever reimburse for non-medical private duty services because that was considered a luxury. It wasn't considered a needed part of the continuum of care. It really was considered just a luxury. And what we saw now is that the regulatory bodies at the highest level, being your U.S. Senate and Congress, really saw that the non-medical services played a vital part in keeping the elderly and disabled population safe. Because although we were fearful of people coming in and out of the homes, most families were very conservative as to the number of people they allowed in their homes. And we tried to keep it very consistent with only the same caregiver going in and providing that, except in those rare occasions where there was 24/7 care. So we really minimized the exposure of the clients to different caregivers. We tried to keep that minimally. And of course, not only did we provide PPE for our employees, but we provided PPE for the clients as well. So if they felt uncomfortable when our caregivers were in there, they had the opportunity to wear PPE. The sad thing about it was with many of the elderly, especially those that are hard of hearing or have slight dementia or Alzheimer's, it really did create a communication barrier. You don't realize how many of our elderly population actually read lips until you have a mask on and they can't understand you anymore. There were also some downsides that came with it, but overall, we really did see, like I said, the best year that we had ever seen across the nation, and continue to do so to this day, as I believe people are fearful to return to those acute care. June through December was definitely.
Did your folks do in-home testing for COVID? Like if somebody said, I have, a cough, would you get into that, or how would you bump up against testing? And then I'll also ask the question about vaccine administration as well.
Absolutely. So Always Best Care franchise system was very fortunate. There was a CMS grant along with, it was the Centers of Medicare and Medicaid along with the Federal Department of Health and Human Services actually went out they were looking for about 10 or 11 large home health organizations that they could provide the testing kits to. They essentially were only going to provide it to skilled nursing, home care agencies, and hospice care agencies. And at the very last minute, they decided that they did want to include at least one large non-medical organization as well into that grant program. And just through connections, we were very fortunate that we were the ones that they reached out to. It was through some of my connections through the years. They reached out to us at I'm telling you, it was the very 11th hour. It was literally like an hour and a half before the grant had to be submitted. Reached out to me. We were able to get our information to them. And so we actually were included in that Abbott Bionex now testing that was allocated to those 11 large organizations. So we were able to provide testing in all of our states with the exception of 2. There was a caveat to being a part of that grant program, and that was that location in each agency had to obtain their own CLIA waiver because it is considered a diagnostic test. In the states of, I believe it's New Jersey and California, in order to obtain a CLIA waiver, they do require you to have a physician on board to support that program. And of course, for a non-medical agency, that's not always feasible. Unfortunately, California and New Jersey did not get to participate in that program, but the remainder of our states did. We did have over 90% of our locations that were able to administer the Bionex test. When it first came out, and it was only for caregivers or healthcare professionals that were going into so at least we were able to provide to our clients that we had the proper screening and this healthcare worker had been screened. Fortunately, about 90 days into the grant program, Bionex was able to go to the government and say, this really should be for both sides of the table. And so at that point in time, we were given the capability to test not only our own employees and caregivers, but anyone that was residing within the client's home as well as the client. So that did make a huge difference for us.
And so then moving forward into December, January, vaccines are available. And I would imagine that your staff would be first in line, or some of the first folks in line, because they interact with the elderly to get those vaccines right along with the elderly patients themselves. Is that correct?
That is correct. We were considered essential workers, and our staff and caregivers were the first ones that were capable of receiving the vaccine. However, I will tell you and be perfectly honest, there was still a lot of hesitation at that point in time as to what were going to be the after effects of these vaccines. 2 or 3 years down the line, was there going to be adverse reactions? And then, of course, all of a sudden, Johnson & Johnson came out, and they had their scare with the DVT and the blood clots. And thankfully, they have that resolved now. But all of that blew up in the news media so excessively, that was all you were hearing. The caregivers weren't just real excited to jump on board with those vaccines. And it was a very slow start. And to be perfectly honest, and I can attest throughout the non-medical side as well as the healthcare side, not only in our organization, but some of my fellow organizations that I visit with the executives on a consistent basis, we are still only seeing about 50% of our care population, in-home care population, who have actually taken the vaccines and gone through the second vaccination process. So it's still an educational process. I believe it's becoming easier to convince caregivers to go and get those vaccines. Of course, now you're to the point that the vaccine is open to anyone, and including children. So the line to get the vaccines are a little bit longer, and the appointments are a little bit further outstretched. So it wasn't something that the caregiver and the in-home care workers were just jumping on board. Actually, I think it was more from the client side that jumped on board because they did not know what the future was going to hold. It's still a slow process, but we're getting there.
Sorry, go ahead.
No, I was going to say the other side to that coin also is, and it's no secret, is there's a caregiver shortage across the nation, and the recruitment and retention of caregivers, as our businesses continued to grow, the population of available caregivers was going down. And there was a whole host of factors that played into that. The federal unemployment stimulus, the stimulus itself, unemployment itself. In some cases, caregivers were being paid more money just to stay at home. So we did face that caregiver shortage as well. So that,
Sure.
played a big
Yeah, so you
significant
can't
part
require
in the
folks to
process
get
as well.
vaccinated because you would further limit your pool of folks that, are available candidates, right? I see. Okay, so
Correct.
now it feels as though things are slowly, the COVID is receding a bit, and hopefully things are going back to adjusted normal. And our podcast is all about talking about what things may remain, some things that maybe you've put in place in operations during
Right.
COVID that were actually probably a pretty good idea and maybe something that we should continue to do. But I don't know how that looks in
Mhm.
terms of the kind of business that you have, because the business you have is where folks are going into other people's homes. And right now they're donning all kinds of PPE. We've already discussed a bit of the challenges with interacting with patients, having on PPE while having on PPE. So is that something that really would be best to be taken back away when the coast is clear? Or what do you think will remain in place?
So really, I think there's two main aspects going forward that we're going to see, especially within our industry. The first of those being is on the non-medical private duty side of the industry, there was only about 30 states that were actually regulated to where agencies had to hold a state license. There was approximately 20 to 23 states that had no licensure whatsoever, no requirement to open an agency. The first thing we're going to see is we're going to see regulations pop up in those other 23 states because there really was no enforcement action within those states unless you were part of a franchise organization or a large organization, say, such as a Medisys or Kindred, to really give you those instructions on what was meant to be. And there is talk on Capitol Hill that if states do not take into account and enact their own licensure process, then there potentially could be, from a federal level, a minimum set of guidelines that would have to be met. So I think that's the first thing that all non-medical agencies are going to be facing is if they're in one of those non-medical states, they are going to see some type of oversight and some type of licensure. The second part of that is just as what you were discussing, infection control and infection control policies and procedures was not something that was really emphasized within the non-medical industry, private duty industry, except for like I said,
Right.
the usage of gloves was basically it. I do see the infection control policy staying in. Number one, whether you're regulated or not, it's just good business sense. It's best business practice. To the extent that it will be full PPE donning and doffing, no, I don't think it will be full PPE, but for the near future, and I'm guessing at least for the next 2 years, I'm seeing and what's going on and the talk that's going on that probably the minimum requirement that will be allowed is at least some type of
Okay.
face mask and eye shield along with gloves. So I don't see the mask portions really going away. We've overcame those obstacles. We've placed whiteboards in clients' homes and written things down. We've found alternative ways of communications. I think we've overcome that barrier, but I do think infection control is here to stay. Just for the sole fact of, just as you said, we're starting to see maybe the little light at the end of the tunnel. In fact, yesterday, the governor of California announced that they're going to start reopening the state in 13 days. And California, we all know, is one of our last to give up and was one of our hardest hit states. And so even that state is starting to slowly open. What I'm really fearful of is that probably by August, September, maybe early October, we're going to be fully reopened for the majority. I think there will still be some precautions in place, but we're going to be open for the most part. And then we're going to be hit with the 2021 flu season. And I think that's everybody's fear is that what is the 2021 flu season going to look like? Is it going to be our typical influenza A and influenza B, or is there going to be some type of SARS mixed in with that
Right.
influenza that could start this whole thing and recycle? And thus is the reason I think that the infection control protocols and at least some enhanced PPE is probably going to be here to stay for at least the next couple of years until we're for sure that we have control over this outbreak. And COVID today is not what COVID was last March. It's a completely different morphed type of disease, virus type. It's not the same virus. It's still referred to as COVID-19 because it's part of that SARS virus. You hear people talking about that become infected today have very minimal symptoms to those that maybe had it a year ago. And it's because the virus itself is morphing into a different aspect and a different phase of its lifetime. And so we have to make sure that we have a good handle on all types of the virus itself before we can completely feel safe. And that's where you get into the biological part. And that's where we have to rely on our physicians at CDC to make sure that they have a good oversight of such. And you hear all different things, but for the most part, our CDC has done a tremendous job, especially on the healthcare side, of keeping us informed and keeping us knowledgeable about how the disease process was changing. It sounds like you're really
in the thick of it as well, reading all of these briefs and that is your job, right? You must have friends at the CDC.
That is my job. And that's what I love. I love this part of it. So I didn't like seeing all the people who suffered and the lives that were lost, but getting into the nit and gritty of it it was good. It was definitely a lesson learner. And it's still a lesson learner to this day, because as we continue to open up different aspects like restaurants and malls and even outdoor activities, there still is a higher regulation for healthcare employees. Take, for example, in the state of Texas, the governor did away with the mandate of masks and freely said anyone can go about in public without a mask, but continue to practice social distancing and precautions. However, that only applied to your general population. Your healthcare workers were still mandated by the CDC to wear masks and particular PPE. That not only included while they were on the job, but while they were off the job within the general population as well. And so that was an educational process as well, because you had to teach them, while you're hearing this on the general population side, you have to realize that doesn't pertain to you because you are a healthcare worker. Right. And so you fall under the CDC healthcare guidelines.
It's never ending. It was never ending when there isn't a pandemic, right? Because medicine and care are always improving and evolving. But this particular event is a sort of a milestone in sort of quick regulation and quick discovery, I imagine. Well, yeah.
Absolutely. And it really did bring on a light to policies and procedures within our industry that needed to be enhanced, and everybody needs to be brought up to par with it. Like I said, we had emergency preparedness plans, but they in no way addressed a pandemic or an epidemiology outbreak of any type. And to be perfectly honest, I would say that the majority of organizations had a emergency preparedness plan in a booklet that set upon it, and it was there. But there wasn't usually a real big need of it, because those other types of natural disasters just don't happen every single day in the same spot around the country. And so it was something that maybe everybody went and accessed maybe once in 5 or 6 years. If that, the remainder of the time it sat upon a shelf and probably never got updated or never had a drill to enact such. And so that was another learning lesson. Just because you have policies and procedures in place, are you actively keeping them up to date, and are you having mock drill to enact such? So I think that was a very enlightening aspect of it as well, is that we may have it written down on paper, but was there anyone within the organization that knew really how to go grab that manual and what to do next? What was the steps 1, 2, and 3? And so that's going to be another enhancement that everybody, I think, has learned to
My
say
guess
about
is
that. We need to know what to do in an emergency
plan is
situation.
pretty solid right now. That now you've got it updated, polished off, and ready to go in case there's anything like this that happens in the next many years. Hopefully there isn't, but that.
Yeah, and it is, but it isn't, because that is really a manual that has to be a working live document. And you have to, just for instance, like I said, approaching flu season, is it going to be influenza A, influenza B, or is it going to be some other type of influenza? and not all are addressed the same. So it really does have to be a live working document that is regularly reviewed. It's part of your quality assurance and performance improvement process. And no less often than quarter, agencies need to be looking at it and adjusting such and making changes and appropriately. And like I said, doing those live drills.
Well, Sheila, it's been a pleasure to speak with you at an executive level about all this too, because it's you have such a high level experience on how to do this. And then obviously you're also in the trenches with all of the regulation and everything. So I just wanted to thank you very much for your insight into all of this. This has been a great interview.
Yeah. Thank you very much. It was a pleasure
to
join you, and hopefully we can do this again sometime.